some 6 rooms, 2 dogs in each room, and then you book in that.
Good morning. Welcome to the Department of Medicine Ground Rounds. Today we have a special guest. I think we'll looking forward to her presentation, but a couple of things about history that I think will end up being relevant to this. On this day back in 1771 was the birth of Marie-Françoise Xavier Bichat, who I knew very little about, was a French physician who actually was considered to be the first to do a number of postmortem evaluations of multiple bodies and examine the different organs and began to get this sense that the body is really a complex accumulation of organs that working together to give you life, and actually define that these organs had different structures within them, that they were specialized and had different functions, even though at that time the cell hadn't been really recognized as a functional unit for life in the body. And he coined the term tissues, and he described 21 types of tissues, and he described all of this in a book called General Anatomy that was published in 1800. He died because he was very exhausted from working several days in the laboratories. He fainted while walking down the stairs, hit his head, and died at age 30. On this very day, just 5 years later, was the birth of Henry Dutrochet, who coined the term osmosis, that process by which a solvent crosses the semipermeable membrane to an area with a higher solute concentration, evens out the concentrations. He did a number of other things, but that's interesting. But related to this, I was fascinated to see that in 1891, on this very day, was the birth of Sir Frederick Grant Bantam. You know who Sir Frederick Grant Bantam was? Our speaker is probably going to tell you or knows about this, but he was the first to extract the hormone insulin from the pancreas. And that was in 1921, and just 2 years later, he shared the Nobel Prize for Physiology and Medicine for that great achievement that actually depended on him understanding structures of the organs that somebody described over 100 years before and died by falling down the stairs. So with that, I leave you with our guest. And before that, Dr. Steve Winters is going to introduce her.
Thanks, Jesse. I think Dr. Best, who worked with him, was a medical student, right? He was worked in the laboratory. He was interested in chemistry and worked on the insulin extraction project from dog pancreases. And so medical students in the audience, get into the lab and you'll win the Nobel Prize. Maybe. In any event, it's certainly a great pleasure to introduce a friend and colleague of many years, Dr. Mary Korytkowski is the professor of medicine and interim chief of the Division of Endocrinology at the University of Pittsburgh. Mary began her career as a nurse, and after that went to medical school at the University of North Carolina in Chapel Hill, and went to the Baltimore City Hospital to study internal medicine. Moved across town to Hopkins, where she was a fellow in endocrinology with Paul Ladenson, who visited us last year and talked about thyroid diseases. And after finishing her fellowship, she was recruited to the University of Pittsburgh, where I was a junior faculty member, by Jack Garrick, who was an eminent clinical researcher in the field of diabetes and insulin action. And Mary was recruited to be in a clinical track, and she undertook the job of taking excellent care of patients with diabetes and beginning a research career related to clinical research in diabetes, investigator-initiated projects, and clinical trials. She became a master clinician, really, and was chosen to head the clinical endocrinology and diabetes clinic, which was set up by Alan Robinson, which was running 10 half days a week in the University of Pittsburgh Medical Center outpatient facility. She grew in the field of diabetes, and at this time has authored 60 peer-reviewed papers and 40 chapters. And she's been a collaborator on many NIH and other grants, and presently one of her grants is obstructive sleep apnea and diabetes self-management, something that we talked about here several times. She's had many positions in the American Diabetes Association, and presently on their board of directors. In 2006, she was appointed to the ADA task force on the inpatient diabetes management, and she was chair of that task force in 2009. Subsequently, she did the same in the Endocrine Society, forming clinical guidelines for the hospital treatment of diabetes, and that's what she's going to talk about today. We all know that diabetic patients are very common in the hospital, representing perhaps 15% of all the people in the hospital at any one time, and that diabetes management is very, very crucial to how any hospital is rated. It's one of the benchmarks by which hospitals across the country are compared. So it behooves us to do a better job in the hospital management of diabetes, and that's what Dr. Korytkowski is going to teach us to do today. Thanks for coming to Louisville.
Well, good morning, everyone. I'd like to thank Dr. Winters for that very nice introduction. It's always nice to go somewhere and then hear about yourself, and because we all get in our day-to-day ruts of what we're doing. I'm going to add my 2 cents in about Banting and Best. First of all, I did not know it was his birthday, so I appreciate knowing that. He did win the Nobel Prize for the discovery of insulin, and he was actually a surgeon. He was not an internist. He was kind of a renegade surgeon. So this was just, I think some people are put on this earth because they have some mission, and I think it was his mission. He was driven to find this product that had something to do with causing diabetes, and they did a lot of research on dogs. Charlie Best was his medical student at the time and worked in the lab with him and worked with the dogs. And when we talk about the Nobel Prize, we always talk about Banting and Best. That's, at least in the diabetes world, those are the 2 names that go together. Charlie Best actually did not win the Nobel Prize, although he never tried to correct it, even though that made it into the daily lexicon. The award went to Dr. Banting and Dr. McLeod, who was the chief of medicine at the University of Toronto at the time. The 2 of them did not get along with each other at all. As a matter of fact, I think they had an intense hatred of each other, but they kind of, lived with each other. And what Dr. McLeod did is he gave lab space to Dr. Banting because he was so driven to find this secretion that might have something to do with diabetes. So it was actually Dr. McLeod who was given the award with Dr. Banting. They both disavowed each other at the time of the award, and Dr. Banting said it was not Dr. McLeod, it was Charlie Best who should share this award. So he immediately shared it. Dr. McLeod came right back and said that Dr. Banting didn't deserve it because he was the one that gave the scientific rigor to the project. And he immediately shared his award with Dr. Kollep, who was the person who actually is responsible for the insulin that we use today. It was a very crude extract that Dr. Banting found, and then it was Dr. Kollep who actually purified this product so that it could be used in human studies. So it's like most Nobel Prizes, it's never just one person. Everyone is always building on the work of others and involving others in the work. even the whole double helix is kind of an interesting story. But anyway, I just added my little historical facts into it. It's always interesting to look to see where things came from. So now just to go into the talk this morning. This is my disclosure. I do have research support from Sanofi. So what do I want to do this morning? Well, as Dr. Winters mentioned, diabetes is very common in the hospital, with the prevalence varying depending on where hospitals are. I suspect that your hospitals in the more affluent suburban areas probably have prevalences below 15%, while hospitals that serve underserved populations who are enriched with diabetes can have prevalences up to 20 to 30%. Another large percentage of patients will have hyperglycemia without having a known prior history of diabetes. So because it's such a prevalent disorder, it's thought that it's important to identify who these people are, because it can affect their ultimate outcomes, both in the hospital setting and beyond. I do want to spend some time going over what the glycemic targets are and what the rationale is for these targets, as well as for modifying these targets. About 2 years ago in the Annals of Internal Medicine, there was a paper published saying that intensive therapy is not indicated in the hospital, and that was interpreted to mean that we didn't really need to pay attention to hyperglycemia in the hospital. It really created a lot of misinformation, and basically what they were really saying is, don't try to treat blood sugars to 80 to 110, that we're not equipped to do it, and it's associated with a high incidence of hypoglycemia. But we do want to control blood sugar levels in the hospital and not let them be uncontrolled. Recognition and management of hypoglycemia is a good way of addressing the major barrier to intensified glycemic management in the hospital. Patients are afraid of it, nurses are afraid of it, doctors are afraid of it. Nobody really wants that. So it's important to have systems in place that prevent this, or at least address it early. And then I'll go through some protocols that can be used. And then I think we'll have some time to look at specific situations like medical nutrition therapy, enteral and parenteral nutrition, perioperative management, glucocorticoid therapy, and most importantly, transitions of care. So there was a group from the Endocrine Society. This was a group representing not just endocrinology, but general internal medicine, hospitalists, cardiologists, and intensivists, who came together to review the literature that existed on inpatient glycemic management and to come up with guidelines for where we should be. And they are evidence-based to the extent that there was evidence. Otherwise, it had to just be a synthesis of the literature to come up with what was considered to be rational glycemic targets. So just to sort of set the stage, hyperglycemia is common in patients with and without diabetes. It is associated with adverse outcomes, both in the hospital and beyond when these people are followed up down the road. The specific targets at which these adverse consequences occur, I didn't include a lot of data slides, but this really sort of summarizes that depending on the study you read, the threshold for where the adverse event starts is somewhere between 110 and 200 milligrams per deciliter. But on average, it is around 150. 150 seems to be the takeoff point where you start seeing higher morbidity, higher mortality, and more infections and longer lengths of stay. So given the prevalence of this disorder, one recommendation of this task force was at the time of admission that all patients should be assessed for a history of diabetes. Do they or do they not have diabetes? But that all patients should have a blood glucose done at the time of admission. In patients who have no history of diabetes and have a random blood sugar of less than 140, nothing more may need to be done unless they're going to go on unless they are critically ill, in which hyperglycemia is even more common than it is in the non-critically ill population, or if you're going to start them on therapies like enteral or parenteral nutrition or steroids, in which case you may want to initiate point-of-care blood glucose testing to determine if they'll develop hyperglycemia. For those who have no history of diabetes but have a random blood glucose above 140, you're not sure if this means anything at all, or it just could be just an isolated mild spike in their blood sugars. But it's recommended that in those patients that they have some additional glucose monitoring performed for about the next 24 to 48 hours. If they have 2 or more blood sugars above 140, it's recommended that you send an A1C to the lab while you're monitoring their sugars. And those with a history of diabetes, if they don't have an A1C on the chart or available to you from the preceding 3 months, it's recommended that you obtain an A1C and initiate blood glucose monitoring. In those patients who were newly recognized to have blood sugars above 140, if their A1C comes back at 6.5% or above using a laboratory method for measurement of the A1C, you've just diagnosed somebody as having diabetes. And this is important for what you'll do with them when they go home. And then, of course, then glucose monitoring should be done while they're in the hospital as well. The diagnosis of diabetes in the hospital, as I said, if their A1C is greater or equal to 6.5, that identifies them. If their A1C is below 5.2, they essentially do not have diabetes. And then the 5.2 to 6.5 is a gray zone. So A1C testing helps differentiate newly diagnosed diabetes from stress-related hyperglycemia. In patients who have diabetes, it allows you to see what their level of glycemic control was prior to coming into the hospital and allows you to intervene so that they can be under better control if they were under poor control at home. Hospitalization is really an opportunity for us to correct things in people who may not have been managed correctly in the outpatient setting. And it also allows you to strategize what their regimen should be at the time of discharge. And I'll end with some discharge planning. Point of care blood glucose testing, it is recommended. These are not perfect systems. There's variability in the meters. Some of the meters will not give you an accurate accurate blood glucose level if the person is anemic. Some meters will go down to a hematocrit of 20. Some will go only to 25. Below that, you really have to verify that you're getting accurate readings with some laboratory measures as well. Because anemia will give you a falsely high reading, polycythemia will give you a falsely low reading on these meters. In general, though, it's recommended that bedside glucose testing be performed before meals and bedtime in people who are eating. In someone who's not eating or they're on constant enteral or parenteral nutrition, that it be done every 6 hours, usually in conjunction with a correction insulin scale for blood sugars above your goal range, and I'll go through some of that. What are the targets that are recommended? Well, for the majority of patients, a glycemic target of 100 to 140 is recommended in the fasting or preprandial state, with trying to keep random blood sugars below 180, but then modifying glycemic targets according to clinical status. Many of our patients are under excellent glycemic control at home, and they're not comfortable letting their blood sugars be above 140 in the hospital. If they can be treated to lower targets without causing hypoglycemia, that could be safe if they're relatively stable. On the other hand, we have lots of patients in the hospital who are very ill with multiple comorbidities. And in some of these patients, it's reasonable to allow some blood sugars to go up to 200. Using 200 as the threshold, because above 200 is where we can get into symptomatic hyperglycemia, as well as fluid and electrolyte abnormalities. What about medical nutrition therapy? Well, this is kind of the overlooked contributor to glycemic management in the hospital setting, but it's a very important component. As you know, we often don't know when people are eating. Now patients are able to order trays when they want, which has really wreaked havoc on the glycemic management part of things. But there's very little data. There's lots of opinion about what diets should be in the hospital. There's very little data guiding what diets should be in the hospital. We actually did one study as our hospital was transitioning from specialty diets to liberalized diets. It was thought this was done as a patient satisfaction initiative and was done outside of recommendations from medical or nursing personnel. But the units were moved from consistent carbohydrate diets, which were being used in our diabetic population, to liberalized diets where patients were allowed to choose whatever foods they wanted. What Nutrition Services said is that they would monitor these, and if patients were making incorrect choices for 48 hours, then they would intervene and put them back on a consistent carbohydrate diet. Well, lengths of stay often aren't that long, and in fact, there aren't enough nutrition personnel to keep track of what everyone's ordering. But we used this as an opportunity to look to see if there were differences. We had 2 cardiology units. The populations were essentially at least very similar. One unit, because it was staged, the introduction of this liberalized diet. The patients were put on the liberal diet, and on the other unit, they were continuing the consistent carbohydrate diet. And what we looked at is what the mean blood sugars were. Let's see if I'm going to press the thing right. Mean blood sugars, peak blood sugars, which were similar. There were no significant differences between these. But the nadir blood sugar was lower in those getting the liberal diet, and actually blood glucose values less than 70 were more frequent in those getting the liberalized diet. Because with the liberalized diet, they were not necessarily always ordering enough carbohydrate for the insulin that they were getting, and no one really knew what they were getting. So we thought that this kind of put us at a disadvantage in terms of knowing how to adjust insulin therapy according to diet. And some institutions have nurses doing carbohydrate counting. Ours does not, and the majority of them do not. But this is the only study I know of looking at nutrition in non-critically ill patients. So we still try to use the consistent carbohydrate diet in these patients, but it's quite variable. What about the pharmacologic management, where we have a little more control over what happens? Well, the options, and again, this is in non-critical care. In critical care areas, we use IV insulin infusions, which can be modified quickly. But insulin therapy is recommended for the majority of patients who need glycemic management. This can be given as sub-Q basal insulin or as a basal bolus insulin regimen. If the units allow or the hospital allows, we have used IV insulin infusions on selected units. In general, oral diabetes medications and non-insulin injectable medications are not recommended. Some of the reasons for this is that sulfonylureas themselves are a cause of severe and prolonged hypoglycemia in hospitalized patients. And in fact, that's how our glycemic management program came into being, as a terrible misadventure with a sulfonylurea-induced hypoglycemic episode that went on for longer than it should have, with an adverse patient outcome. Metformin is contraindicated in the setting of renal decreases in renal blood flow or use of iodinated contrast dyes. The thiazolidinediones are not really used very much anymore. GLP-1 therapies are often associated with nausea, so we would not want to initiate those in a hospitalized patient. And certainly they don't work in patients who are insulin deficient. And then there's really no data, or very little data, regarding any of these agents, including the newer agents, the dipeptidase 4 inhibitors or the newer SGLT2 inhibitors. So maybe this will be something in the future, but it is not right now. This is a study that we did in our institution with the sulfonylureas, looking at hypoglycemia in this group of patients. As I mentioned, a lot of the sulfonylureas have a prolonged duration of action and a long half-life, so hypoglycemia can go on for a while. And we did a case control study of 234 sulfonylurea patients, 117 who had a hypoglycemic event, which we defined as blood glucose is less than 70, and 117 who did not. And what we found was the independent risk factors for hypoglycemia in these patients were those above 65 years of age, those who had a GFR of less than 30, or if the sulfonylurea was used in combination with a basal insulin. So those are the places where we thought about prohibiting their use in the hospital, but we sort of moved towards these recommendations, that these are patients who should not receive sulfonylureas, possibly at all, and definitely not in the hospital. What about sliding scale insulin? It's not going away. So we all talk about sliding scale insulin. And it kind of gets a bad rap, in part deservedly and in part non-deservedly. There are some places such as Rush in Chicago that has actually abolished sliding scale insulin. However, I don't know that I could abolish it because there are times where I need this. The best term for sliding scale is correction insulin, because you're correcting a blood sugar that's above where you want it to be, or supplemental insulin would be another term. So it's not recommended as sole therapy for patients who have known diabetes requiring glycemic management, or for patients treated with insulin before coming in. So if someone was on a basal insulin alone or a basal bolus insulin regimen, or if they have type 1 diabetes, using sliding scale insulin alone is not the way to do it. It sets the stage for both hypo and hyperglycemia. I already talked about the terminology, but when can it be used? When can correction or supplemental insulin be used alone? Well, again, these patients who come in with blood sugars above 140, sometimes they're above 200, and you're just not really sure where they're going to go with this. You don't know these patients from before. So we will, when we order the bedside glucose monitoring, we'll order a correction insulin scale as well, and then observe them for the next 12 to 24 hours to see if they'll have an ongoing insulin requirement, or if this was just something associated with stress hyperglycemia at the time of admission. So it can be used for described periods of time to determine whether or not there will be an ongoing insulin requirement. Once an insulin requirement is established, then it's time to switch to scheduled insulin therapy. This is an example of the correction insulin scale at our institution. There are several that are published. They're all pretty much the same. Everybody has their starting point and their ending point. We describe ours as low dose, moderate dose, and high dose, and then we allow a patient-specific scale. This is now all on computerized order entry. When we had it on paper, it looked much nicer. But you can see our low dose scale starts at a dose of 1 unit and goes up to a maximum of 6. The high dose scale starts at 3 units, goes to a maximum of 340. But if someone felt that they wanted to be on some other type of regimen or starting at a different level of blood sugar, that can be ordered. The moderate dose scale is the average place where this all starts. What our correction insulin scale is based on? Well, not much. We kind of pull these numbers out of our head. There are insulin sensitivity indexes that can be used for calculating correction scales for patients in the outpatient setting where we prescribe prandial insulin according to a certain blood sugar level and tell patients to increase the dose by so many units for each incremental range of blood sugar. And there are formulas for that have been created and have actually been validated. They're about 40 or 50 years old, published years ago. In general, these are the scales we use. Part of the reason why we standardized our scales a number of years ago is we found in just one survey of 1 week in the hospital, there were over 40 different sliding scales being used in the hospital. They were starting at different levels. Some started at 100, some started at 200, some started at 150, some started with 1 unit, some started with 10 units. It was chaos. And there was no standardization whatsoever. It was all physician specific and not really based on anything. So this has helped to standardize things in the hospital and is very acceptable. You'll notice here this term HTP, which stands for our hypoglycemia treatment protocol, which was our very first step in developing an inpatient glycemic management program. If I had to do it all over again, this is exactly where I would start again, because it really forms the basis for any other protocol that we've introduced into the hospital. This is used for any blood sugar less than 70. This is a nurse-initiated treatment protocol. It can vary from something as simple as giving a patient a glass of apple juice if they're awake and have a blood sugar of less than 70, all the way to the nurse being empowered to go ahead and treat with intravenous 50% dextrose and start a dextrose-containing intravenous solution before calling the doctor. So our doctors are never called to be told that their patient has hypoglycemia. What do you want me to do? They're only called after the patient has been treated, and what do you want to do with the regimen from here? Do you want to make any changes? And this is actually, you can't get rid, it's very hard. We're not at the point where we've gotten rid of all hypoglycemia, but it has significantly reduced the frequency of severe hypoglycemic events because things are treated at the time of recognition rather than waiting for treatment. So I said scheduled insulin therapy is recommended for most patients. That usually consists of, similar to the outpatient setting, a basal insulin preparation of your choice, glargine, detamere, NPH, a bolus or prandial or nutritional insulin that can be regular or one of the rapid-acting analogs, or together with a correction scale. And this, again, refers to just the supplemental doses for glucoses above the range. We do encourage that the correction insulin be the same as the bolus or prandial insulin that's used. So patients aren't getting one shot for meals and another shot for correction, so that these doses can be merged. And we do have a diabetes resource nurse group that meets, and we certainly address each of these issues on a monthly basis. What about, should it be regular insulin or should it be rapid-acting analogs? There is not much data about this. This is one study that actually was done at the Brigham, where they actually randomized patients to receive rapid-acting analogs or regular insulin. And as you can see, those who received the rapid-acting analogs had milder reductions in their blood sugars after eating compared to those getting regular insulin. There was also a little less hypoglycemia in those getting the glucemic as the rapid-acting insulin preparation compared to the regular insulin. But in general, we are using the rapid-acting insulin preparations for patients who are eating because it's much easier to time appropriately to the meal. They can get it as they're eating or immediately prior to eating rather than getting it 30 minutes ahead of time, which is the optimal dosing with regular insulin. But we use regular insulin for our patients who are NPO or who are on continuous enteral or parenteral nutrition, mainly because of the longer half-life. With the rapid-acting analogs, we feel like we'd have to dose more frequently of every 4 hours. With regular insulin, we feel like we can extend the dosing to every 6 hours in those particular situations. So patients who are eating rapid-acting analogs, and that's the way most of this is moved. Patients who are NPO or on continuous enteral or parenteral nutrition, regular insulin every 6 hours. So what correction scale should you use? There's the low, moderate, or high, but there are really no studies that define this, none. But our residents asked us for some guidelines for how to order correction insulin or which scale to use. And these are general guidelines. And again, we haven't really validated this, but this is what we use. So if the total daily insulin dose is less than 40 units, if a person is lean or has type 1 diabetes or has a low GFR, meaning they're likely more insulin sensitive, we recommend that they use the low dose scale. For the majority of patients with type 2 diabetes treated with insulin, we recommend starting with the moderate dose scale. And if they're on very high doses of insulin, greater than 100 units per day, well, that's when the high dose scale may be most appropriate. But we try to steer people away from the high dose scale with the idea that if you're needing to use high dose correction insulin, chances are you need more of the scheduled insulin and not to rely on the correction insulin alone. So how to order basal bolus insulin therapy in the hospital? We use weight-based calculations. There's been several studies that have published that, these results of these studies. Again, people who are insulin sensitive, lean, renal insufficiency, or age above 70 will calculate the starting dose as 0.2 to 0.3 units per kilo per day as the total daily dose. If they're obese and more insulin resistant, we'll start at 0.4 units per kilo for blood sugars less than 200 and up to 0.5 units per kilo for blood sugars above 200. Once you've calculated the total daily dose, in general, we recommend that about 50% be given as the basal insulin and the remaining 50% be given in divided doses as the prandial or nutritional insulin. This could be 3 doses a day in someone who's eating. It could be 4 doses a day of regular insulin given every 6 hours if they're on continuous enteral nutrition. And then the correction insulin scale is added. So for example, a patient who weighs 100 kilograms, just make it easy, and their blood sugar is 268 and they're persistently above 200, the estimate would be that they get 0.5 units per kilo or 50 units a day, 25 units given as glargine, with 8 units given as Lispro before meals, and the correction insulin scale. The important thing about this, though, is that ordering insulin is not something you can do once and then leave the patient alone. There are changes in insulin sensitivity that occur on a daily basis in patients who are acutely ill in the hospital setting for a variety of reasons, because of tests, because of medications, because of their clinical status. So the glycemic profile has to be reviewed at least on a daily basis with modification of insulin doses. Patients with renal insufficiency, I mentioned earlier, are a group that are particularly insulin sensitive. This is a study that was done by David Baldwin, again at Rush, where he actually used 2 different weight-based scales in patients who had eGFRs of less than 35 that were randomly assigned to the higher dose of 0.5 units per kilo per day or a reduced dose of 0.25 units per kilo per day. In their goal range was 100 to 180, where they achieved similar levels of glycemic control in both groups, even with the low dose, no significant differences. There was much less hypoglycemia with the lower dose scale, but the important thing here is even though hypoglycemia was lower, it was still there, even with this giving 50% of the dose. So similar levels of glycemic control, but less hypoglycemia with half the dose of insulin compared to the other groups. So why they had the similar glycemic control is really hard to know, although maybe there's some downregulation of receptors when doses that are high are given. An alternative method that's been proposed by Dr. Perez at Emory is this basal plus scale. It actually is a lot of our ideas are revisited ideas. This was actually proposed a number of years ago to put people on basal insulin alone so that your weight-based calculations are just 50% of what they were before, and use the basal in combination with the correction insulin. He was able to show similar glycemic outcomes in the population at Grady Hospital with type 2 diabetes, which is what primarily the type of patients they have there. But here, again, for giving basal insulin alone, your calculation would be 0.1 to 0.15 units per kilo. For obese patients, again, if blood sugar is less than 200, starting at 0.2 units per kilo. If they're obese, at 0.25 units per kilo. And he observed that this can work well. These are the results of the study. They had about 150 patients in each group. The mean daily blood glucose was equivalent in these 2 groups, and of course better than compared to the group receiving sliding scale. And I put the asterisk here because this included the patients who had to get rescue therapy with basal insulin added. Treatment failures, of course, that was very high in the sliding scale group, low in the basal plus group. Hypoglycemia was similar, both mild and severe hypoglycemia. And so this actually raises the issue about a lot of people consider insulin a scary drug. And I have to say, I was afraid of insulin therapy when I first started using it. I wasn't sure what I was doing, really. And I finally sort of have a structure for how to use it all these years later. But if you calculate a dose, say, oh, this person, they're obese, their blood sugar's above 250, I've got to use 0.5 units I've got to use 0.5 units per kilo, and you calculate a dose of 50 units, and you think, I can't do that. Well, ask yourself, what can I do? Because you can't always get to glycemic control in a day. I wish we could, but in the outpatient setting, we would accept this, that it would take us time to get to our goal. Critical illness is a different area, different than non-critical illness, where we can get there fast with IV insulin infusions. With sub-Q insulin, we've got to start things and then see where we go. If you feel like, well, okay, I feel okay about giving the glargine, but not the bolus, well, then start a basal plus regimen, and then add in the short-acting insulin later if needed. If you feel like the doses are just too high, I kind of call it the gut factor. Like, what What can I give that's going to let me sleep at night but also get the person on the road to having reasonable levels of glycemic control, because it may take a couple of days. So use these calculations as your guide and then ask yourself what you can do. But just getting them on a scheduled insulin regimen is the important part. What about modifying the regimen to prevent hypoglycemia? Well, the guidelines state, again, review the blood sugars daily, reassess the diabetes therapy for blood glucose values less than 100, and to modify them definitely if blood glucose is less than 70. Dr. Nzuki at Yale actually did the study with one of his fellows that he also has not gotten to publication yet. But they actually looked at antecedent blood glucose values in patients who experience severe hypoglycemia, which is defined as a blood sugar of less than 40 milligrams per deciliter. And what you can see is that those who experienced severe hypoglycemia compared to those who didn't have severe hypoglycemia were more likely to have blood sugars in these lower ranges compared to those who didn't. So definitely here you can see if blood glucose is less than 70, 23% of these patients had blood glucose is less than 70 prior to the episode less than 40. So it really lends support to this recommendation that the therapy be modified as blood sugars drop below 100. And the level of 100 is probably a reasonable lower limit for the majority of patients. Is weight-based insulin dosing safe? Well, this is one of the rabbit studies from Dr. Umparas, who has now actually published several using the algorithms that I've introduced to you earlier. These were patients with type 2 diabetes, the same dosing, weight-based dosing that I went through with you for the obese patients, giving half as basal, half as rapid-acting insulin analogs. And these were the results. And you see, they didn't get there in a day, but by the second day, they had blood sugars below 180 in the group randomized to receive the basal bolus insulin compared to those in the sliding scale. This number would actually be higher, except that, again, a fair number of the patients in the sliding scale group needed rescue therapy with basal bolus insulin, and so they're each included in the intention to treat group. And, of course, the concern is always hypoglycemia. 3% of subjects in each group had hypoglycemic events defined as blood glucose is less than 60 for this study. None had a blood glucose of less than 40. So it certainly seems to be a safe regimen to use. And in fact, safer, I think, than using sliding scale alone, because we're not reacting to highs and lows all the time. You're getting patients into a more even control. So just to go through a few situations for patients receiving enteral nutrition, in general, we recommend that monitoring of glucoses be initiated with initiation of enteral nutrition because it is an independent risk factor for hyperglycemia. I'm showing you a protocol we used in a study. Half the patients in this study did not have diabetes did not even have hyperglycemia before being started on enteral nutrition. So if their blood sugars stay below 140, no need to continue monitoring if they're at their maximal nutrition supplement. If this is what we used if their blood sugars were above 140. Actually, we used it if they were above 130. Then we initiated a basal insulin once a day or in divided doses with regular insulin given every 6 hours, and again, in combination with correction insulin. If they had 2 or more blood sugars above 180 in the prior 24 hours, we would add 25 to 50% of the correction insulin to their scheduled insulin. And then once all blood sugars were between 100 and 180, we would continue the current regimen. An important point that I want to mention that we have also introduced is abrupt discontinuation of enteral nutrition in patients who are receiving insulin therapy is a major cause of hypoglycemia and sometimes severe hypoglycemia. So embedded in our order sets for any patient receiving insulin is if they are on enteral nutrition and it is abruptly discontinued, again, this is something the nurses do and then call you, they are started on an IV infusion of 10% dextrose at the same rate as the tube feeding. In reality, it would have been better if we calculated out what carbs they were getting and adjusted the rate that way, but we found that that was an easy order for everyone to understand and initiate. And again, it has really eliminated the risk of hypoglycemia with enteral nutrition in our institution. It's been very effective. What about TPN? Well, we know that there are lots of studies showing adverse outcomes with patients receiving TPN who have hyperglycemia. This is the only intervention evaluation that I'm aware of, and this comes from, again, from Dr. Baldwin, where he actually just did a query of of 8 different medical centers about what they do and what their glycemic outcomes were. The optimal regimen that he came up with was adding insulin to the TPN solution, which had not the lowest blood sugars, but the lowest blood sugars with the lowest incidence of hypoglycemia. And the ratio that he came out with was adding 1 unit of regular insulin for every 10 to 14 grams of dextrose. Going up is needed. If somebody doesn't have a history of prior diabetes, sometimes using 1 unit for every 20 grams might be a safer place to start. Perioperative glycemic management. This is a very old study from 1971, but I really liked what it showed because these were people without diabetes, and it just looked at the percent change in blood sugar in these patients as they went through the surgical procedure and post-operatively, where their sugar level increased even to a greater extent. These were all patients who received general anesthesia, which is a greater metabolic insult than are those receiving epidural anesthesia, where there was really very little effect on their blood sugar levels. But this just tells you if blood sugars are going to increase this much in someone without diabetes, they're going to, even if they increase to a same percentage in somebody who's hyperglycemic to start with, you're going to have very high blood sugar levels in surgical patients. And hyperglycemia, blood sugar levels above 150, is definitely associated with adverse outcomes in a surgical patient population. So the recommendation is, this is something we all do, we kind of do it rotely, is to give 50 to 100% of the usual basal insulin dose before surgery. For patients receiving premixed insulin, we say to give 1/3 of their dose, which is really 50% of the basal dose prior to the procedure, or if they're having prolonged procedures, that IV insulin infusions are the optimal way to go. And we've actually done some protocols with our anesthesia group. One of the things we did is this whole thing about cutting the insulin doses before surgery. There was actually nothing in the literature that supported this practice. So we did this with our same-day surgery unit and the anesthesiology in Pittsburgh, and we actually looked at outcomes. I mean, we all have to do quality improvement now. We need to do quality improvement projects. They need to do quality improvement projects, so we merged our projects. And so this counted for both departments. But we actually looked, it's data from about a year of 584 patients who came into the hospital following the protocol that I just showed you. Although the protocol we used was 50% of their basal insulin, which we had a lot of debate about. I don't think you have to do that with glargine insulin or possibly even detamir insulin. But we were releasing this to be used by the same-day surgery nurses who contacted the patients. So we thought it was a safer way to go. And actually it was a fairly effective way to go. The majority of patients came in with blood sugars between 70 and 200, which we had defined as our goal range. A very small incidence of hypoglycemia, and a larger but still small percentage of patients came in with hyperglycemia. And we actually took this a little further and had a protocol in place for what to do with these patients when they came in, that in the interest of time I won't go through. Yesterday we talked a lot about glucocorticoid-associated hyperglycemia without going into a lot of detail in this morning's lecture. A proactive treatment can reduce the amount of time someone spends with hyperglycemia and can even abort some of the severe hyperglycemia associated with glucocorticoid therapy in the hospital setting. Again, similar to enteral and parenteral nutrition, Even in patients who have no history of diabetes, it's important to start glucose monitoring because about 60% of these patients will develop hyperglycemia with doses of prednisone or prednisone equivalents above 20 milligrams a day. This is one regimen that's been published in sort of a descriptive paper of a practice. This is at Medical College of Virginia, where they administer NPH insulin together with the dose of prednisone or salumedrol, prednisolone, dosing it for each 10 milligram increment in the dose of prednisone, a 0.1 unit per kilo increment in the dose of NPH insulin, up to a maximum dose of 0.4 units per kilo is a place to start. Again, the gut factor comes into place. If you find yourself calculating a dose of 0.4 units per kilo and think you can't do that, ask yourself what you can do, particularly if this is a patient who told you they became hyperglycemic previously. And then this transition from hospital to home is very important. Again, we getting back to that checking an A1C at the time a patient comes into the hospital. If their A1C is less than 7, they can go back on the regimen they were on before coming into the hospital. If their A1C is between 7 and 9, well, maybe they can restart their outpatient medications and they can go home on the basal insulin at a reduced dose with plans to follow up for their diabetes care following discharge. If their A1C is above 9, they can possibly go home on the same doses they were on in the hospital, with the caveat that if they're on any of these therapies that are going to be discontinued that we know are associated with hyperglycemia, they be given a taper for what to do with their insulin doses, or they could go home on a basal plus regimen with or without their oral hypoglycemic agents. So just to summarize, we know that hyperglycemia and diabetes are common in the hospital, that it is important to identify these patients early in their hospital stay as a way of addressing this proactively and intervening early to prevent severe hyperglycemia. A measurement of an A1C at the time of hospitalization can help guide what you're going to do with this patient when they go home. If maybe they need insulin for the first time, so insulin teaching can be started early. The recommended glycemic targets in non-critically ill patient populations are 100 to 140. Scheduled basal insulin with or without bolus insulin is recommended for the majority of patients with inpatient hyperglycemia. Modifying the insulin regimen is important after reviewing the daily blood glucose results to prevent both hypo and hyperglycemia. And then some therapies such as enteral nutrition, parenteral nutrition, glucocorticoid therapy, actually use of octreotide, some of our immunosuppressive agents, do put our patients at risk for hyperglycemia. And insulin-treated patients do need to continue their insulin therapy when they are made NPO for procedures or for surgery, although the doses very likely will need to be modified. So I would like to thank you all for your attention. Another picture of Pittsburgh for Dr. Winters, and I think I have a little time for questions here.
Thank you so much. That was terrific. I have a question for you. And it's also a comment. When I ran it, you focused mainly on management of hyperglycemia outside of the unit,
Yes.
outside of critical care. One of the things I tell my trainees in the critical care unit is that in the past 2 decades, our advancements in the care of these patients has not been about new drugs, new machines, new strategies. It's been all about logistics and centralization of care. And it sounds like very much is the same, that the tools were there, but finding exactly how to do it and standardizing care, making sure that everybody follows the protocol is really, really, really crucial. And you brought up the concept of quality assurance studies and so forth. Tell me more about that. How do you go about tackling these issues as you've done it over the past decade or so to ensure that the patients in your hospital are better cared for in diabetes control?
So that's a good question. The majority, not all of our the studies or the data that I've shown you here has been done through a process of quality improvement, which has actually worked very well. I mean, Randomized controlled studies are the gold standard, but you need funding, and it's almost it's going to be difficult to randomize patients now. But with the quality control, how should I describe this? All of our fellows need to do quality improvement projects, and this whole area of inpatient glycemic management has grown. We knew what happened when we addressed hypoglycemia. That was our only task, was to develop a hypoglycemia treatment protocol back in 2001. What happened is that it unmasked all the reasons for why there was hypoglycemia in the first place. And even as we were developing these protocols, it came to us that, oh, our pump patients are having their pump stopped, or this person's been on a pump and nobody's looked at their blood sugars. And so we just started developing these. We have a multidisciplinary committee that is made up of representatives from critical care, from anesthesia, from nursing, from risk management, from hospital administration, from endocrinology, general internal medicine. We actually are a system-based committee now. We started out as a small group, but we review what's going on. Every single protocol that we've implemented has been implemented only after being tested on a unit so that we can show that it's safe, only after engaging the nurses. You heard that I was a nurse before going to medical school. No protocol is going to work unless you engage nurses, because these are protocols, but the nurses are the ones who do them, both in critical care and outside critical care. So we engage the nurses. We have them review order sets, how things are written, and so that they get to read through it and see, does this make sense? Can they do this? Can they not do this? And as I said, this diabetes resource nurse group has branched off from what we have, this diabetes patient safety committee. We've been doing this now for 12 years, so it certainly didn't happen overnight. But now we're actually seen as the group to come to if there is an issue that's causing concern. Our latest issue that we'll probably be publishing soon is this whole thing about more and more patients are coming into the hospital with insulin pumps. So we have a protocol for our patients on insulin pumps. But then the question is, can they wear their pumps during surgery? And again, there's very little that's been published. Well, two of our fellows actually took that on. Again, we did it in conjunction with some associates in anesthesia, where we did a project together, and we actually found it was a protocol. It didn't mean that everybody stayed on their pump. Some did and some didn't, but a protocol for what to do if the pump was stopped, what to do if the pump was continued. And I think it's sort of been, it means you talk to a lot of people and you interact, but I think that's how quality improvement happens. But you have to engage the people who are going to actually be doing this. A lot of times people ask us for our protocols, and it's not just getting a protocol. It's really engaging the people who are using it.
Great. Questions?
Yes, sir. Seems like these protocol things are somewhat labor-intensive in hospital settings for a lot of parts of the staff. So I was wondering, would you think there's issue of migration to a patient support call center, like the businesses that they have with infusion pumps?
Yes, we actually do have our IV insulin infusion on the computer. It's an in-house program that people use. In terms of decision support, where you can merge the electronic ordering system into these management systems, we've actually tried to build a few things. And actually, it's very interesting. I forgot what program you were using here, but some of these EMRs, Cerner, Epic, I think Centricity, have protocols built into them, but they don't release them for wide use. So you have hospitals inventing them themselves across the whole system. A lot of our protocols were developed initially on paper, and then they merged into electronic ordering, which was a bit nightmarish. It was very hard. The paper part was easy. The electronic part has been more difficult, and we're still refining that. The decision support issues, I don't know if you're finding this, but there's like a whole group that looks at this click fatigue syndrome, where you have messages coming up like, if this, then do that, or your patient has had too low blood, to have a message come up, your patient has had too low blood sugars, Do you want to modify the regimen? We tried to have a dialogue box come up for sulfonylurea therapy. It goes through all kinds of committees, and they decide no, they don't want to put this pop-up box there. So I think we're just in the early stages of that whole thing. I think we'll move in the direction you're saying, but I'm learning that at the same time, not being a computer person. So we're now having to interact with the IT people in terms of building these things.
Question? Yes, sir.
You know, really, like for many years, we didn't really know if we were trying to that has in the hospital. That there is that slide that counts. So, I mean, we have no diabetes.
If they're A1C, right, if we've initiated insulin therapy in the hospital, I mean, again, these are patients hopefully we had a chance to see for a few days. We will discharge them home, and there's all kinds of caveats to that. But if their A1C is above 7, we will often discharge them home on insulin. Some of these patients may be able to transition to oral agents down the road, but we can say we know insulin is working, and that question about oral agents can be addressed later.
Last question.
Actually, Dr. Winters and I were talking about this yesterday. I think professional societies mean well, but you know, even this, so I was on both panels for there was the American Diabetes Association, American Association of Clinical Endocrinologists consensus statement on inpatient diabetes management, and then the Endocrine Society comes along a year later. It was published a couple of years later. And there was a lot of political upheaval, even about the fact that endocrine wanted to come through with it. And we have all these societies publishing their own guidelines, and you're correct, they're dense. And even in being in this field, I find it hard to keep up with everybody's different guideline. I hope that we do move in the era where we can agree, these professional societies can agree and have an approach for how to do this. In critical care, you must get all different kinds of guidelines from infectious disease and metabolics and nutrition, and you know, we try to stay with the best we can do, but I do think there's a lot of refinement that needs to come through, and it's not just going to be publications, but it has to be practical use in making it real and how to make it real in the hospital. So that's a good point.
Great discussion. We want to thank you for coming.
Oh,
this
thank
was
you.
wonderful presentation, and a good way of presenting us this concept of quality assurance and getting more people engaged in that. And there's an initiative the department will be starting about getting all the divisions into developing specific quality assurance projects for every year, and we'll be discussing that. But your picture reminded me of Roberto Clemente.
Oh.
MVP, 3,000 hits, multiple Golden Glove awards, and played with Pirates for a number of years. And he played with a Louisville Slugger. And we decided to give you a Louisville Slugger because I think you might get more of your doctors to follow instructions. If you do rounds like this, you just do rounds like this. You don't have to correct me. And it says, Dr. Mary Korytkowski, Medicine Ground Rounds, University of Louisville, November 14, 2013.
Oh, well, thank you so much.
Thank you
I'm
for joining us.
honored. Thank you so much.
Thank you, everybody.
My husband is going to love this.
We're going to send it to you by mail because I want to make sure.
Yeah.
But we try to get anybody who comes here from the outside. We want everybody to have that in their office.
Oh, wow.
See, it says Louisville.
Yeah.
And it's fun, and it reminds you of us.
Oh,
Okay?
thank you. I brought Steve a terrible collar.
Oh, is that right?
You know, the Steelers.
Well, it's very nice to meet you. So, how do you and Mark know each other?
Well,